everybody. Welcome to the third installment in the Salome Ask an Expert. I'm Boitumelo, Sebambo, your host. Today we're talking PMS and periods with Dr. Heidi Frere. Evening, Doc. How are you doing?
Fine, thank you. Thanks so much for having me.
Oh, it's always great. It's always great having a chat with you. For everybody else, we are joined by Dr. Frere. Dr. Frere is passionate about helping women find relief through integrative and functional medicine. So it's quite a great match for our team and our product at Salome. Doc, I'll just introduce how we're going to work and then we'll jump over to you. How the webinars work is we've received a host of questions from everybody who's joined. But everyone else who never got an opportunity to send their questions or who wants Doc to elaborate a bit more and give you more detail perhaps on what you're talking about, please post your questions. I will just go through the questions with Doc. And if you miss anything, you can always go back on our website, which is www.salome_range.co.za to get hold of this webinar and the last two. This will be up in a week, but the last two, the one was on fertility and the other one was on menopause, are already on our site. Doc, I think let's kick it off. Perhaps maybe introduce yourself to everybody and then we can get into the questions.
Great stuff. So Dr. Heidi Frere, I've been a general practitioner for over 20 years, qualified in 1995 at KZN University. I've had a bit of an interesting career with lots of general experience in all sorts of things, emergency medicine, anesthetics, yeah, you name it, I think I've done it. Oncology was one of my interests, and I saw a lot of female oncology issues there, and I think that's probably what's contributed to my interest now in female health. I have no doubt, and I think what I've leaned towards now is more prevention, rather than sort of waiting for something to happen. I think that's where my passion really lies, in prevention. So I'm passionate about functional medicine. That's also known as integrative medicine, not commonly known terms, but my other interest is medical aesthetics, and that's kind of where I find my creative outlet. So I've done several courses through the University of Florida, organizations like A4M, IFM, the School of Applied Functional Medicine. I've done an advanced diploma in aesthetic medicine. I've a thriving practice in Bryanston, in Johannesburg, where I'm really, really passionate about female and male hormone balance, medical weight loss, and so on. So female hormone health is really such a rewarding treatment to offer to women, especially now. I find women are under an enormous amount of stress and strain the last 2.5 years, but just generally, I think women are asked to do way more than they would usually do. So I think they're just requiring lots more intervention and help from us medical professionals.
Thanks for that intro, Doctor. I think for all the women on the webinar, it's just great to have more and more women doctors, because I think then you walk into a space where you're not gaslit. You speak about something and the doctor either has got experience or can pick up a phone and phone other colleagues. I myself am on the path where I'm changing my doctors to female doctors, and it's just such a pleasant experience, rather than nothing against the male doctors, but I just think that a lot of our needs were not met because there wasn't a lived experience. So we are always grateful for doctors.
To that point, I think empathy is such an important part of what we do. we have to empathize with other women in order to know what they're going through. To be heard is an important part of the treatment journey. Yeah.
So let's get into it. Doc, like I said at the start, is today we're talking PMS and periods. One of the things around what we do at Salome is really just demystifying everything that has to do with women's reproductive health. We just want people to be able to know their bodies, people to be able to speak about what's happening. And like you said, prevention. One of the opening questions that kept coming up in the request for Q&A, which is quite surprising, is everybody wants to know what is the normal cycle. What is a normal menstrual cycle? And I think let's start there, then we can just unpack.
Yeah. I think to that point, Boitumelo, the questions there were an enormous number of questions, which it's overwhelming, just the need that's out there. It really highlights that a lot of women and young girls, women ranging from their 20s to their 40s, were asking questions. And I think it just affirms what we're doing tonight, just in terms of educating. So in terms of a normal menstrual cycle, we would typically expect a 28-day menstrual cycle, counting day 1 as the first day of the bleed to 28 days being the end. Day 1 of the menstrual cycle, typically 3 to 5 days of bleed, and then the repeat of the cycle at day 28. So, give or take 2 days before or after, some women experience a cycle of 30 days, some women experience a cycle of 26 days. Every woman is unique, and I think that's the important thing to take away from that. Day 1 is typically what we say is the heaviest day. It's not necessarily day 1. You could start lightly spotting on day 1, but that really is the norm, 28 days. And I think to answer one of the next questions, which was, how do we know when we're having a heavier menstrual cycle? For me, it's simply when you're reaching in the shopping aisles for that heavier tampon, for those longer sanitary towels, thicker. There's something going on there, and that should typically alert most women or moms or dads, because we mustn't exclude the dads, but that's typically where something is going awry.
So just a question, Doc, which is, why are these cycles different?
Okay, so typically day 1 to 14 are usually what we can count on as being regular. Day 14 is typically where we would ovulate, and we would be fertile 2 days before and 2 days after. So, for women using a more natural contraceptive method, that's where they would want to use condoms, etc., or avoid intercourse during that time. But it's the second half of the cycle that is predominantly slightly different for most women. And that's where progesterone really has a role to play. Levels are most likely, for most women, low during that second half of the cycle. And that's, I think, what usually accounts for that irregularity.
Okay. You had a great image earlier, Doc, that you I don't know if you still have it. Perhaps if we look at it, it would help to just explain that to everybody, in terms of just what you've talked through, and then we can deal with the questions that talk about what happens before the cycle, because we need to get into PMS. But I think let's start off looking at what normal is in terms of the cycle.
Yeah. So I think what's important to highlight is that with this hormonal axis, we have essentially 3 glands intricately involved. There are several more glands, but I'll focus on 3. It's the hypothalamus, the pituitary, and then the gonads. And you'll see from the graphs that LH and FSH, let me go to the top one, which is the ovarian cycle, and it's basically where a little egg then becomes, more mature and potentially then fertilized to then produce a fertilized egg if intercourse has happened. The second one is just temperature change. We can usually expect a temperature change around day 14. And then there's the hormone, luteinizing hormone, and then there's the hormone FSH. And these are hormones that are stimulating the ovaries to produce the hormones estrogen and progesterone. In the 4th row, the estradiol and progesterone. Estradiol, we in South Africa usually refer to as estrogen, but it's the progesterone in the second half of the cycle that's quite variable. And it's usually because of this hormone, luteinizing hormone. And that's often where issues arise, where women complain of a breakthrough bleed, which might be a bit of spotting. And it really is because progesterone is our calming hormone. It's the one that's most susceptible to irregularities when we're undergoing a certain amount of stress and strain in our lives. And there's whole complexity around that. But that really is one of our first hormones to start declining. And it can start declining as early as our mid to late 20s. I hope that answers the question.
It does. There's 2 other leading questions from that. One is, I'm just looking at this and it looks like 14 days, but I'll ask you and not answer it. One of the questions is, how long is ovulation supposed to last?
Okay, so ovulation really does start, if we can see from the top little row there, really does start at day 1. At the bottom of the graph, you can see 0 days. And this this mature egg is really available for fertilization at day 14. And so we're potentially fertile 2 days before, 2 days after. And that really is the most predictable phase, the follicular, what we call the follicular phase. It's the luteal phase that then becomes a little bit more erratic, prone to be affected by lifestyle factors, stress responses, other hormones like insulin, testosterone. So a lot of outside factors that can then start affecting that second half of the cycle, which is then the luteal phase, which is then meant to be stimulated and synchronized beautifully by luteinizing hormone.
So, Doc, if I'm understanding you properly, you're saying 2 days before and 2 days after is possibly where you're most fertile.
Yeah.
That's a little bit of a mess because 2 days before, most of us are PMSing.
Absolutely.
It really is a little bit of an unfortunate one.
I know. And it's potentially the last thing you feel like doing. But then day 14, you're experiencing a little bit of pelvic discomfort potentially from this egg that is maturing, because it's producing its own inflammatory hormones and so on. And it's sometimes messing with our gut a little bit, but that really is the time. 2 days before, 2 days after. Yeah.
Another ovulation question is, if you're ovulating, must you have a mucus discharge, or is it okay not to have one?
So I think the mucus discharge is a really nice indicator. The thicker, the clearer, the better. The better indicator of a good mature egg being produced. So, you know, for the layperson out there, it really is a telltale sign that there is a mature egg there.
Okay.
Available.
Okay. So one of the things you mentioned, Doc, was just around spotting. And somebody asked if spotting in between periods regularly, is that normal, or is there perhaps a need to see a doctor?
Was that, sorry, I think we just broke signal there for a little bit. Was that bleeding in between?
I can see we did break signal. Even your screen has moved. Out there, I can see you again. So the question is should I be worried if I'm spotting between my periods?
Okay, I think that that would definitely indicate some form of hormonal imbalance, and it really does, I would say, depend on where within your cycle that spotting occurs. One of the important things for me as a medical practitioner is also just to ensure that my female patients are having regular pap smears. So is that spotting happening in association with sexual intercourse? And have they had their regular pap smears? That's integral in gathering all of the information when we're trying to unpack when the spotting occurs. Because that could indicate an abnormal pap smear, an inflamed cervix, an infection that needs to be addressed and treated. It's not always hormonal. Sometimes there is something going on within the vaginal wall and within and around the cervix.
Okay. So I'm going to backtrack us a bit, because there is a question that says, what is spotting? I always just have to remember this. So maybe let's start at the back and say, what is spotting? And then that would at least assist the person in terms of understanding the question that you asked.
Okay. So spotting really is, I mean, you know, we've established, I think, what is normal. It's typically a 2 to 3 day menstrual bleed. You need to use tampons. You need to use sanitary towels. Spotting, you could probably get away with a panty liner, and you would notice the spotting. It's usually often because of its passage through the vaginal canal altered its color and become brown in color. And it really is sometimes because of a very thin endometrial lining in the uterus and not enough estrogen to build up that endometrial lining. So back to that previous diagram, in the first 14 days of a menstrual cycle, where estrogen really is climbing and peaking, our endometrium is thickening. And it really is just Mother Nature's way of setting up a beautiful environment for a fertilized egg to be implanted. And so when that endometrial lining is too thin, one of the smaller blood vessels might just be broken through and cause a little bleed. Provided that pap smear is normal, I think, you know, we mustn't run off to the doctor with the slightest sight of spotting. I think if it's consistent, that's really the important thing. Is this something that's happening consistently for you? My magic number is 3. Then yes, absolutely visit your doctor, visit your gynecologist, and get this investigated.
Okay. I think that's clear. It sounded like it was regular, because this is from one of the previous questions that we got. In the spirit of backtracking, Doc, what is PMS, and why is everything happening during PMS? So I think one of the things is, people want to know what are the symptoms, and then I think we can go into the treatment. But there's a question really about what is it?
What is, sorry, we broke up a little bit there. I think it's when we change from the slides to us having a conversation. Was the question around what is PMS?
Yes, that's the question.
Okay. So I think in the week leading up to our period, so we've got the first half, which is this dramatic increase in estrogen, and the second half of our cycle, which is this dramatic increase in progesterone, which usually reaches its peak at about day 21 of our menstrual cycle. In our PMS week, both these hormones dramatically decrease, and they have a profound effect on our mood. And so typically in the premenstrual week, we can experience, because progesterone is a very calming hormone, the role of progesterone is really to support potential pregnancy. So when there isn't that pregnancy, the hormone declines, and progesterone is calming by its very nature. I think I can't remember the last time I saw a pregnant woman having a hissy fit over anything. Pregnant women are sedate and calm because their progesterone levels are through the roof, and that's the way it's meant to be. So in that premenstrual week, our progesterone levels decline dramatically. Our estrogen levels decline as well. We can be prone to migraines, this irritability, just irrational anger. Parents often will mention that a teenager just becomes just another person. It's almost like having an out-of-body calendar, and there's so many apps. There's so many wonderful apps out there. Unless you're keeping that kind of track record, it's sometimes hard to know. And for parents, I would encourage them to really keep a track, so that you're aware, you're sensitive, you're empathetic, and you're kind to your children, your female, your teenagers during that premenstrual week.
So then, yes, it
did. Through Boitumelo?
It did, Doc. It did.
Okay. Thank you.
I think then the questions are, you've spoken about mood, and people are asking, how do they alleviate the symptoms? Somebody else spoke about mood. Somebody else asked about appetite. Fatigue is big. Sugar cravings. And I think the one that is less spoken about, we do talk about mood, but we never really delve into the depression. So there is a question just around how to deal with any and all these symptoms.
Yeah. So I really think the symptom of depression is because of the estrogen decline. As I mentioned, estrogen and progesterone decline to then cause the menstrual bleed. And one of the reasons I think that depression is so profound is because of this enormous decline in estrogen. Unfortunately, this is just a natural cycle, but there are so many other things we can do to start alleviating and supporting this premenstrual tension or syndrome week. It's commonly in Western medicine, allopathic medicine, treated with either antidepressants, sometimes oral contraceptives. There are many ways to treat it, and I think it really just depends on the severity and the difficulty that people are really experiencing during this time. I mean, there's mild symptoms of low mood versus serious depression where you're battling for a teenager, battling to go to school, for an adult battling to go to work. And so it really depends on how this is impacting your life. And I think based on that, you're going to decide on the level of intervention that you're prepared to take. Is it going to be an antidepressant for a length of time or the week of that period? Or is it going to be something a little bit more natural, altering a few lifestyle factors and changes, lifestyle change, where you just mitigate the amount of stress I think that you're under in that premenstrual period. You're not going to take on an enormous amount of tasks during that time. You're going to rest more. Sleep is so important. You're going to not do excessive amounts of exercise. You're going to veer towards things like Pilates, yoga, walks in nature. They sound so basic, but they really have a profound effect. And I think for a family or for a woman or a teenager that's really attuned to what's going on with her body and has this menstrual calendar or app, those are the things that she's going to find most useful. And then, of course, we'll get into chatting a little bit about some of the herbal extracts that can help. But this is a lovely plan that I call the 7-pillar plan. And it's just really healing our hormones and genes with lifestyle medicine. And it's so basic. But the reality is we don't do a lot of them. It's eating whole foods, going back to good protein, good vegetables, good fruit intake, avoiding refined carbs. It's moving. But in the premenstrual week, we really want to be gentle around this. It's sleep. Those 8 hours of deep sleep are really, really important. It's what we're thinking about, reducing stress, relaxing and soothing, finding ways to calm ourselves, meditating, connecting with family. I think during the premenstrual tension week, the tendency might be to withdraw, but I think we really need to engage. And this is where parents, the role of parents is so critical. The role of informed teachers at schools is so important. And I think this is where the role of employers with their employees, predominantly female, it's going to be critical. And then we need to detoxifying, not to get too complicated, but the role of gut and liver health is so important when it comes to managing and balancing our hormones. What we put into our mouths really does have an enormous impact on our hormones. And so sometimes we have to find ways to detoxify. And there's simple ways. They don't have to be complex. Exercise. When we sweat, we perspire, we detoxify. We're drinking adequate amounts of water. When we're eating a clean diet with whole foods, unprocessed foods, we really are detoxifying. So those for me are simple methods that we can start with.
A lot of this sounds counterintuitive, Doc. You talk about detoxifying. I know when I'm PMSing, I just want more and more sugar. So there's a lot about it which is quite a conscious decision around don't do it. I know I possibly just want to sleep in a little bit more, but you're saying wake up, walk. You don't need to do heavy exercise, but still, wake up and do something. So I do think it is quite, as I said, counterintuitive. Like you said, you can just be left alone, but you're saying actually be in the company of people, find things to just bring back the endorphins and any other happy hormone that could be there. And I know that with our team at Salome, our thing is as you said, natural. We believe that premenstrual cycle should be treated with natural products. We believe the same for menstrual pain. We believe the same for heavy menstrual bleeding. And that's why we spend all this time developing natural-based products for both pre-mens, for heavy menstrual bleeding and menstrual pain. So, I'll get myself into finding acting in a counterintuitive way. One of our earlier questions that we got was, somebody said they're 45 and they're finding that with age, PMS is getting worse. Is this something that could be happening? Is there something else behind this? What could be driving this?
Okay. Yeah. So I think to your last point, Boitumelo, I think, yeah, it is counterintuitive. We kind of get into the rhythm and the habit of just going with the cycle. And what I'm just encouraging people to do is to be attuned to what's going on with your body. I'm encouraging families, I think, to be attuned to what's happening with their teenagers, their female teenagers. And when you see a pattern, intentionally try to change it, make changes, because insanity is just basically doing the same thing, and it can happen. I mean, we were not informed. I'm 50 years old. My parents did not know any of this. I think they left me just to slam doors, scream at everyone, and act out my rage during my PMS week. But had they been informed, they would have been able to handle me, I think, a whole lot better. And so I think that's the message. Let's be intentional. Let's be attuned. Let's just be more informed. To your next question with regards to the 40-year-old woman, she's really going through, I think, one of the most difficult times in her life. This is the time of hormonal chaos. And it really is, I think, one of the, if we're thinking of the urban woman, corporate, typical Johannesburg type scenario, I think any middle income type of woman is basically going to be under an enormous amount of stress, holding down a job, running a family, and navigating all sorts of things like load shedding, etc. So, so one of the important things that I think we need to know and understand is that when we look at progesterone, which I mentioned was our calming hormone, and we look at cortisol, which is our stress hormone, the building blocks that make cortisol also make progesterone. So when we're in this stressful state of flight, fright, freeze, the typical sort of stress scenario within an urban society, it's really then causing the body to channel the building blocks that it would have used for progesterone to now shift and move to cortisol to cope with the amount of stress that we're then under. And what does this do? This causes us to be more irritable, to have poor sleep. We struggle with insomnia. We gain weight. We often battle with a lot of heavy menstrual bleeding, and bloating. Lots and lots of water retention. So when we looked at the normal cycle with estrogen and progesterone really just forming this beautiful harmony, like I'm often talk to my patients about an orchestra. Our hormones really need to be in synchronicity, speaking to each other and beautifully balanced. When we're under an enormous amount of stress, our estrogen dominates and our cortisol dominates and our calming hormone goes down. What happens? We take it out on our families. We're irritable with them, the children that we love, the partners that we love. And then what do we do at the end of the day after we've been irritable with our employees or co-workers or whatever? We beat ourselves up.
It's
an enormous amount of guilt, and the cycle just continues. And so, this thing of hormone balance and restoring hormone balance is just really, really so important. And we just really need to understand the importance of it and how it impacts on life and on families and on work, productivity. It's vital.
Yeah. Look, I think it was also made worse with things like lockdown and people getting COVID, because COVID itself had its own fatigue issues.
Yeah.
So the last years, I think, have been extra difficult on numerous people, particularly women.
I think if our cortisol levels were ever at a higher, I'd be surprised. I mean, I think we've been under an enormous amount of stress in the last couple of years. It's unprecedented, and I see it in my practice with women. And the other thing to mention is that perimenopause can span 10 to 15 years. I think a lot of women think that it's this moment in time where they go through menopause, and it's not the case. There's this decline as we reach menopause, and the first hormone to decline is progesterone.
I learned about that last week during the menopause webinar. I was ever so shocked that you could be perimenopausal from your mid-40s until your mid-50s.
Yeah.
What are we supposed to do for a decade of imbalance? Just
mind-blowing. Yeah. Mind-blowing.
That's good.
And I think it's important to, sorry to interrupt. I think we've got a little bit of a lag.
Back to you, Doc.
I think this whole thing of stress, and I think also understanding Mother Nature, and how things were meant to be, and how modern society has changed the way things were meant to be. And we were probably meant to be pregnant at the age of 18, if Mother Nature had a way. And we were probably meant to finish our families in our late 20s. But modern society has made it such that women in my first child was born at 39. So I know career, we put our careers first, we put studying first, and it just delays having children, and the impact of that is enormous. But our progesterone levels decline as early as our late 20s. So we really need to start, just rethinking this thing, and how do we deal with it? How do we navigate the changes that we've made in society, so that we also achieve optimal fertility? Because I think as women, we want everything. We want it all. We want the career. We want the family. We really do want it all. Why not?
Why not? You've brought it up, Doc. Somebody wants to know if the irregular menstrual cycle, or if an irregular menstrual cycle can lead to, or does it lead to, infertility?
I think it certainly needs investigation. And I would certainly say if it's consistent, then it does need investigation. And what do I mean by investigation? I mean a doctor's visit to start with. I mean a pap smear, without question, a pap smear. And then we can really test our hormone levels. We can understand what our levels are. We know what optimal levels are. We know what low levels are, and we can supplement them. We can bring them up to where they need to be, to normalize things. But first we need to understand, is there disease? is there what we call in medical terms pathology? We always want to be responsible and exclude pathology. And often with an irregular menstrual cycle, there's sometimes underlying conditions like endometriosis, polycystic ovarian syndrome. We really need to unpack that and get to the heart of that. So it's not a simple answer. I would say absolutely engage with your GP or your gynae to get to the root of it.
Okay. Look, I think it's with everything that we're talking about, and we said it at the start, is one, the relationship with a doctor that you trust, that hears you out. Two, it's really understanding our individual bodies and our individual cycles. I think that goes a long way. And since I started doing that and actually having an app, I know it. I can predict every single thing. Not to say I do the right things like eating properly, but I know on the morning when I wake up and all I want to do is eat sugar, what is happening. that has helped. That has helped a lot.
That sugar craving, just to give you a little hint there. I mean, it's your body's way of just trying to cope with the stress of what it knows is coming, which is PMS, right? Go for some dark chocolate.
At least I'm that disciplined. At least I'm that disciplined. At least I'm that disciplined. We've got a question here. We've got a question. You've been talking about pap smears and going to see a doctor, and somebody says they had a pap smear earlier in the year, but since the pap smear, they've got constant pain before peeing and constant discomfort. Is this normal? And I'm assuming if it's beginning of the year, well, she said this year rather than beginning of the year.
Yeah.
But I just want to know if this new discomfort is normal.
I think sometimes we can build associations in our minds around something that we're experiencing this month and associate it with something that happened 8 months ago, 7 months ago. The two are not necessarily linked. And when there's urinary discomfort, that's often a urinary tract infection. And so I would say that must definitely be investigated. And I doubt that the two are related. In the person's mind, they may feel that they're associated, but I doubt it. I'll definitely go back to the doctor who did the pap smear, have a simple urine dipsticks done, and have it investigated.
Okay. And then in terms of, we spoke about it also earlier when you're talking about just polycystic ovarian syndrome, infertility, and other underlying conditions. One of them is a lot of women are talking around heavy bleeding. And maybe let's start with what is considered heavy bleeding, and then we can go into what are the options for heavy bleeding.
Okay. So I think I mentioned the moment that you're reaching for in the grocery aisle, the heavier tampon, the longer sanitary towel, the thicker sanitary towel, something should be alerting you. One of the things that happens as a knock-on effect of a heavy menstrual bleed is iron deficiency anemia. And it's something that I see so commonly in my practice. And it causes so many issues. So that's the one thing that should alert you is needing heavier sanitary wear. The second thing is bleeding through the night. If you're sometimes bleeding through pajamas, through linen, that's not normal. The other thing, just bleeding through your work clothes and needing to embarrassingly go to the bathroom and change your clothing, or having to leave work. There's something going on. Excessive clots, that's a problem. And then the knock-on effect of that is iron deficiency. And typically with that, there's an enormous amount of fatigue. But I've found in my practice that women soldier on through iron deficiency. I see some ridiculously low iron levels, and I don't know how women are getting out of bed and they're running marathons. And I think it's just the way of women, they'll just forge through. But there are other things to look out for. There's hair loss. There's another condition we call angulostomatitis, and it's just these cracks at the corners of the mouth. There's really brittle nails, changes in the skin. We really need to be aware of those things that are signs, but they're later down the line. I think the first thing is just track your cycle. Is it 2 days? Is it 3 days? Is it 5? I mean, I have a lot of women thinking that 7 days of bleeding is perfectly normal. What's the underlying cause? It's the progesterone deficiency. It really, really is.
I just looked at my nails as you were talking. I just looked at my nails as you were talking because I don't have hair. It's falling off now. I'm like, oh my goodness.
And a sign that we look for as doctors is what we call pallor. We stretch the lower eyelid and look for what we call pallor, which is paleness. Yes. And so if you're losing color, that's another clear indication. People around you will notice it perhaps before you do. Especially when you're having, sorry, Boitumelo, especially when you're having good amounts of red meat in your diet and green veg, which are great sources of iron, then you've got to know that something else is amiss. Yeah.
I do think it's slightly more difficult for the darker skinned girls for us to figure out the appeal. It takes
the people around you. The people around you know.
More, and I think maybe the pale might be misunderstood as a glow or color or a good light.
I promise you, you'll know.
What does one then take for anemia? What do you do?
Right. So it really depends on how low it is. But I'm a firm believer in fixing the root cause of a disease. I don't believe in band-aiding a problem. And so establishing what that cause of iron deficiency is paramount. That's gonna lead to a happy patient. So if I can resolve her heavy menstrual bleeding, resolve the progesterone deficiency, if that's the cause of it, and sort that out, then her iron will recover. But there are some wonderful iron supplements out there. I personally administer intravenous iron, but there's also intramuscular iron injections. It just depends how low the iron is and just how much it's impacting on people's lives. To go through alopecia, hair loss, is so traumatic for women. And the recovery time takes so long. So the quicker I can get a woman's iron level up so that they can recover their hair growth, for me, that's first prize.
Yeah. Doc, I'm looking at the time.
Yeah.
We'll have a couple of questions, but I think maybe one of the other popular ones, perhaps in the last 8 minutes or so that we've got left, is there were a lot of questions around oral contraceptives, if oral contraceptives are the answer for menstrual pain and for heavy menstrual bleeding. I've got a different opinion and an answer, but I'll let the expert answer.
Okay, so I really am of the belief that oral contraceptives should not be used in young teenagers who have not had regularity established already in their menstrual cycle. So by that, I mean, if the cycle is not at every 28 days, 26, 30, 32, whatever it might be for that unique individual, I do not believe that an oral contraceptive pill should then be used for the purpose of creating regularity. I think it needs time to establish regularity. It may need other interventions, but an oral contraceptive pill, as the name suggests, is for contraception. It's a synthetic hormone that I think has huge health implications. I think we've become too blasé about prescribing them as GPs and gynecologists. I think we've used them for other purposes, and we shouldn't. I may come under fire for that, but so be it. But they're contraceptives. They meant to help and assist women with family planning. That's their role. They have risks. They have potential side effects. And so they should be used judiciously and responsibly. That's my view.
Yeah. I'm in absolute agreement with you, Doc. I really do agree. And I think because we're seeing that girls are starting their periods much younger than we did, so if girls are starting at preteen at age 11, and these will go on till your mid-40s, if not 50s, I think we need to have a different relationship with our bodies. And one of the things that we believe in as the Salome team is, let's also look at natural products that are effective, of course, but have far less side effects. If the science backs it up and there's far less side effects, rather take that, because you'll be using that from the time you are 10 till the time you are, in your 40s. So 3.5 decades of something that is negatively impacting in your life is not something that we are fans of. So I think that's the one thing that I definitely am totally.
We agree. Yeah.
Absolutely agree.
Yeah.
Doc, I'm going to give you the last 3 minutes of the last 4 minutes. You have gone through the questions. There were a couple of messages that you wanted to get across.
Yeah.
I know you had many other things you wanted to say, and time has flown, but I'll hand it back to you, and then we'll close.
Yeah. So I think in my introduction I mentioned functional medicine, which is not widely known. It's not a term widely known, by the layperson necessarily. I think when people are seeking help, medical help, they're going to a general practitioner, homeopath, gynecologist, and they're not necessarily informed around functional medicine. Functional medicine really looks at the root cause of disease. And it's understanding that at the heart of everything, any sort of hormonal irregularity or disease, inflammation is one of the things that is causing problems. Hormonal imbalance is potentially another. Nutrient deficiencies is another. But even deeper than that, and Kerry has a slide just to demonstrate, and we call this the functional medicine tree, but it really is going to the heart of what is at the root cause of disease and treating that. Because I think a lot of the time, as general practitioners, as gynecologists out there who are my colleagues, and I love them dearly, we're often band-aiding a lot of issues. We're treating symptoms right at the top of the tree, and we're not delving deeper down into the causes. And there are sometimes things that we don't even necessarily discuss in a 10 to 15 minute consultation. It's not possible. So my consultations are usually 45 minutes to an hour long, because I do need to understand what lifestyle factors are impacting on someone. And stress is a huge one, as we've discussed with the pandemic and COVID and load shedding and all those wonderful things. So, so unpacking that, treating that, and then, I talk about states of dis-ease and then states of disease. And I talk about things downstream and upstream. Downstream is where disease is diagnosed, something potentially like endometriosis, polycystic ovarian syndrome. And I, with natural medicines and herbal extracts, move my patients and work them up back to a state of dis-ease over time, and then back to states of health. And that's really ultimately what we want. But it really does mean that it's a professional patient partnership with lots of trust, and it's a journey. It requires an enormous amount of partnership and an alignment and adherence to protocols and to lifestyle change. And it's about empowering people and giving them hope. That really is what I'm passionate about. Thanks, Boitumelo.
Thank you so much, Dr. Heidi Frere. I've enjoyed our chat. I think the next chat we must delve into endometriosis, fibroids, and cysts, because I think those are the other biggies that we didn't get an opportunity to cover. And as we're closing, there are questions around that. So we'll definitely do this again to cover that. But to everybody else who attended and asked questions either tonight or earlier on in the week, thank you again for your questions. This webinar and the others will be available on our website, which is www.salome_range.co.za. As I mentioned earlier, the first two webinars, the one was on fertility, the other one was on menopause. This one will be on our website in a week. Please do visit and get this, and actually all sorts of other information. Some of the questions, some blogs. Dr. Frere has responded to similar questions before and was on Espresso talking about the same things again. So thank you very much. And to Team Salome, as always, thanks for the technology behind these webinars. Thanks, Doc. Good night, everyone.
Thank you. Good night, Boitumelo.